Hello, as many of you know, I'm Lydia Isaac. I'm the Vice President for Health Equity and Policy at the National Urban League, and this is part of our monthly Health Equity webinar series, which addresses the social determinants of health and pertinent issues that are happening in the African American and Black community. I'm so excited today to be joined by two distinguished colleagues and scholars on LGBTQ plus health, so lesbian, gay, bisexual, transgender, queer or questioning plus health. And we're just going to have a wonderful conversation about the importance of thinking about LGBTQ health, why it's important for us to have representation in our society, not only in the medical field, but in research for LGBTQ health, and just to have a conversation about why we're here. This is Pride Month. This is June. We're really excited to be able to have this conversation during Pride Month and be able to actually get these scholars together. And I just want to also say, before I introduce them, thank you to Dr. Watts, who's actually on vacation, but is doing this for us because this is so important for him. And so I think it's really important for us to have this conversation. And so I'm just going to introduce our distinguished panel very quickly. I'm going to let them say a little bit about themselves, and then we're going to get into the conversation. So Dr. Wheeler, I'm going to start with you. So we have here with us is, and I'm very excited, and also Dr. Wheeler and I realized that we've known each other for way back, and so we just figured that out, but Dr. Darrell Wheeler is the president of the State University of New York at New Paltz, and Dr. Keith Watts is an assistant professor at the University of Kentucky College of Social Work. And so I'm going to start with you, Dr. Wheeler, if you want to just introduce yourself a little bit more, talk a little bit about the research you've done in this field and why this is such an important topic.
Certainly, certainly. It's a pleasure to be here, Dr. Isaac, and what a pleasure to meet you, Dr. Watts. As you heard, I'm the president at State University of New York in New Paltz. By training, my degrees are in social work and public health, and I've been involved in HIV research for a long time. In fact, the year I did my dissertation was the year Magic Johnson identified as having HIV, which changed the course of the kind of research I was doing and the impact that that statement had on Black and African American communities. And I've been in this line of work since that time. I've had the privilege and honor of leading HIV prevention intervention studies. I think one of the ones I'm probably most known for is doing one of the first studies on Black, gay, bisexual men and the use of PrEP as a prophylaxis against HIV acquisition. And we demonstrated high utilization of it and maintained a very high retention rate. And that was done through the HIV Prevention Trials Network. And now I still don't get to do as much research as I used to, but I co-lead the HIV Prevention Trials Scholars Program, which is with it in the network. And we're entering our 14th year, and about 8 years ago, we expanded from domestic and also into international markets. But we have over 60 scholars from underrepresented communities who've gone on with their doctorates and medical degrees and are advancing the state and science of health equity research in HIV. And to me, at this stage in my life and in my own work, that's a signature, and look forward to talking about that and issues of equity for LGBTQI individuals. Thank you.
Thank you. Well, hello everyone, and as I echo with Dr. Wheeler said, I'm super happy to be here with you all and excited to be with talking to you about this really important topic. Just a little bit about myself. My training is in psychology and social work. So my doctoral education was particularly in social work. The experience I have working with thinking about LGBTQ populations, I worked with broad in mental health services, but oftentimes a lot of my work had to interact a lot with LGBTQ populations. I worked as a behavior specialist at a psychiatric residential treatment facility for youth in Atlanta. And then I also spent some time as a counselor and case manager at a place called Welcome House, which was a transitional home for dually diagnosed adults. So typically when we say dually diagnosed, they're usually presenting with some type of maybe substance abuse in addition to some type of mental health diagnoses or disorders. So I did that work for a while, and then I decided to, just to kind of get a better understanding of the mental health perspective of working with LGBTQ populations. And so that's when I decided to go ahead and get my doctoral training And so now, in my role as a faculty member in the College of Social Work, my research focuses a lot generally on the mental health and well-being of LGBTQ populations, but also looking at some subpopulations in particular. So I've done a lot of work with LGBTQ youth, as well as Black LGBTQ individuals. Also did some research with LGBTQ social work students. I do qualitative and quantitative studies. So looking at the big data, as well as looking at, the individual experiences of folks and capturing that. And currently so my research focuses a lot on belongingness experiences. So the way in which the ability to belong to identity-based communities. So if you think about, for example, someone who identifies as Black and LGBTQ, really focusing on how do we understand the role that having a sense or lack thereof of belongingness to these communities that you most likely feel a connection with, what role does that play in your mental health and also just your health in general? So, because we know that your ability to connect with individuals who share the marginalization that you share, oftentimes are the sources of support that you also have, if not the only sources of support that you can often access. So my research focuses a lot right now on looking at the role of belongingness. And even to the point now where I'm about to start doing some research looking at the connection between cancer mortality risk, so allostatic load, and the connection that has to your sense of belongingness for sexual and gender minorities, because I really think that it's important that we look at the holistic understanding of how health shows up. So.
No, I love that, Dr. Watson. Actually, you just made me think of a question and saying that with belongingness and thinking about, some people would say, why do I care about LGBTQ health, right? So, as a Black woman, some people say I have double minority status. A lot of folks will say people who are queer or LGBTQ, I have a double minority status, but some folks will argue that being Black might be the one that's more important. So I do want to talk with you both, because I love that you just said, why is it focusing, particularly in our communities, on LGBTQ populations important for their health? Either one of you can take this, or both.
Well, I'll go ahead. I think if we just think about it generally, as I said a minute ago, oftentimes when you are someone who has these marginalized identities, it means that you have experienced a lot of marginalization in society, and therefore you've been left out or overlooked in a lot of spaces, and including in healthcare. So whether that be mental health services or physical health in general. And so then what happens is the places that you can actually access some type of support, some type of resources are typically going to be people who share these identities with you, because they share this experience of marginalization. They understand what it is to move around the world and to know that you're not going to be treated as the same as individuals who may look different than you, who may hold identities that are different than you, that typically have been given more power and deemed as more important in our society. And so, thinking about like what you said about, identifying as a Black woman and as someone who identifies Black and queer, that means that you're dealing with marginalization in a lot of different ways, because you're dealing with marginalization and oppression from the larger kind of society that we have that is typically very anti-LGBTQ, and also typically very, we privilege the experiences of men. And then we also typically privilege the experiences of people who are not of color. And so what happens is, I love that you bring in, this idea of intersectionality, and that now you have to really understand, okay, well, what does it mean for someone who's a Black queer woman to really, what kind of community is there for you to rely on? Because it doesn't mean that you can go just into any LGBTQ space and think that you're going to be treated the same or accepted, because we know a lot of times there's still a lot of the larger kind of structural oppression that happens in our society is also going to be present in these spaces. So a lot of LGBTQ spaces, it's, you see typically usually Eurocentric. It's usually ran by, managed by, and usually predominantly populated with, white people, white LGBTQ people. So you still are likely to experience some type of marginalization, even in LGBTQ spaces that are supposed to be places that you can access community and support. And then if you look at going into spaces that may focus on the needs or center the needs of Black LGBTQ people, there's still the likelihood that individuals who are perceived to be or identify as masculine or as men are still going to be privileged in these spaces and are still going to get, first dibs, if you will, on what is needed.
Dr. Wheeler.
Certainly, I can only compliment the things that Dr. Watts has just said. And when you ask the question, Dr. Isaac, about why is this important, for me, it begins with the fact that this is a matter of social justice and equity, that health in the United States is a poorly defined resource, and it is parceled out and commodified along a lot of structural, political, and economic realms. And individuals, as Dr. Watts pointed out, individuals and communities who are considered marginalized, and we have to put quotations around marginalized, because marginalization doesn't happen as a function of birth. It happens as a function of structural oppressions, and they're intentionally used against groups of people. So let's not think about marginality as something that is immutable within a social structure. It has a functional role to keep one group in and another group out. We'll stop there, but stay focused on the question of why is LGBTQ health important? Because as an issue of social justice and equity, as an issue of equitable access and responsible access to healthcare, healthcare for all should be the focus. Individuals who manifest as LGBTQI integrate non-binary thinking or life-lived experiences into how they approach healthcare deserve the same access and resources in healthcare as anyone else. Just like the difference between the three of us, but certainly between male health and female health is recognized in that, you know, I'll go see the urologist. I'm old enough, I better go see the urologist, and you might go see the gynecologist, Dr. Isaac. But having access to the resources that you need for people to understand the dynamics of your body, the ways in which allostatic load or any other condition, you know, how stress relates to conditions in which you live and manifest within your body, how behavioral, these things have to be understood if we want to bring communities forward in terms of their individual and community level indicators of health and health outcome. One other factor why it's important is because we see the overlay of multiple epidemics known as syndemics living on the lives of individuals who are in marginalized statuses. So today in HIV world, we see a rampant increase in syphilis among particularly men, and disparately men in the South who are Black. And we know that if you're acquiring syphilis, you're at a greater risk for HIV. And so understanding the dynamics of behavior, society, and physiological determinants of health are critical, and they have to be understood within the total lived experience. And just like we talk about LGBTQ health, we have to really interrogate this and talk about why don't we talk about heterosexual health in some of the same ways? Because men are not necessarily known for having the best health habits universally. And if we talk about this honestly, we would want an agenda that focuses on a number of attributes that people bring to the table that may be predictors and or consequences of the statuses that they hold. And when you talk about integrated identities, you don't live in just one. You are not Black or LGBTQ, you're Black and LGBTQ. And understanding the whole person is a critical role. And so I just conclude by saying the way I started, it is a matter of access and health equity, that if we want the best outcomes, we must understand people in their totality, their wholeness.
And, I'll add to that. One thing that I think about Dr. Wheeler when he spoke is I know I think oftentimes when I speak to individuals who in the trans community who speak, for example, about, medical visits where because they present as feminine, it may not be, whereas a healthcare provider may it be appropriate to say, let me give you, for example, like a prostate screen, right, for cancer. Well, if you are not really quite competent in understanding how to navigate healthcare with individuals who have, gender identities that are non-normative, then you may say, okay, well, this person presents as feminine or as a woman, therefore, then these services are not going to be necessary for them, or you may even cross your mind. I remember also speaking to individuals who identify as trans men, right? So that means going from female to male, and they are not getting oftentimes the kind of the healthcare services they need for someone who has like a vagina, right? Like vaginal healthcare services, right? Because you may present as masculine, therefore your health is not the quality of healthcare that you receive, and appropriate healthcare is not given to you because the people that you're working with in the medical system don't understand or recognize that, how someone may identify and how they may express their gender does not negate the onus on you as a medical provider to make sure that you have a full sexual history, a full physical history of that person to really understand what it is that they need uniquely, without just coming to assumptions based off of how someone may present and these kind of normative ideas around who gets what kind of services.
So ideas of, Dr. Isaac, may I?
Oh, yes, yes.
So ideals of what are normal and what is normative are societally set. Again, back to not being immutable. They're not dropped down from on high. They're not like oxygen that's required for everybody to breathe. They are things that are human made. And the things that are human made actually interfere with some of the processes that you're talking about. So a physical exam is determined based on someone's outward, as you just described it, someone's observation of who you are. They're bringing their knowledge to the table, but they're also bringing their biases and assumptions. So back to why this is an important issue, it is important for the recipient of the care to have competent, well-trained professionals working with them, but it's also important for professionals to be trained to be present and to be aware of their own biases and their own assumptions. So I'm very happy that you spoke to both, the context of if you're in a primarily African-American or Black healthcare network, whether that's LGBTQ or not, compared to and or held against if you're in an LGBTQ primary healthcare. Either can be disruptive to you receiving quality care if the provider, the medical provider, but also the provider system, because healthcare is not just about the interaction between you and a doctor or a nurse practitioner or the equivalent. Healthcare is about the system of services that you receive that actually may start with the promotion of health. It may start when you walk in the door at the healthcare agency. It may start I go to enough healthcare agencies in my own research. It may start with the security guard sitting downstairs who looks at you a certain way, or it may be somebody that you know from the community and you're from a small community and you're like, I can't go in there because I'm going to be judged. All of those factors become part of the equity agenda when we're talking about health, that someone who is cisgendered, presumptively heterosexual, walking into a healthcare system may not take into consideration the concerns and fears of being outed, being treated differently. And that is a barrier to healthcare, which has to be addressed, because you don't even get to the point of receiving quality interaction with a provider if you won't go past the front door.
I love it, Dr. Wheeler. Actually, you kind of got me onto my next question about this idea of, being outed or the stigma around certain identities in our communities, and particularly in Black communities. And I'm not gonna pick on a particular area in our country, but where we're seeing the persistent problems and prevalent problems in our communities with people having stigma, not being able to get access to care, or feeling like they can't come out or they can't be their true selves because of reactions that are happening, not only in the community for themselves, but in the healthcare system. And so I think it would be well for this group in particular talk about, as Black people, let's just be honest, that we have not always been as supportive of LGBTQ populations, and what that does to those members of our community who are questioning or know that they have that identity. But the wonderful thing about our communities is that our communities are so cohesive and loving and supportive. And that's why people do hide their identities, because they want to stay in that cocoon that has supported them throughout their lives. And particularly Dr. Watts talking about the mental health impacts of having to live somewhat a double life.
I think you're muted.
Oh, thank you. Yeah, thank you. I was. That is a broad question. And so maybe I'll start in on this one first and then pass it off to Dr. Watts. I mean, you pose a number of interesting things. And in addition to being a researcher, I've been a practitioner. I served in the military. I went to medical school for a year. I've done so many different things and had exposure along the way. So my worldview is informed by these multiple perspectives. But I would say that you talk about the cohesion within the Black community, and you said, let's just for a moment talk about the Black community. I would say that within the Black community, I actually push back on some of the narrative that we're not inclusive. We're inclusive within a narrow band of what we believe is normal. And so if I'm wrong, you or others can chime in, but why do we see so many shows that always have a gay person in the choir? The beauty shop always has a gay person in it. So we accept, if you live within a structure and a norm that we can comprehend, it becomes messed up if the basketball player comes out and says, I'm gay, or if the ballerina says, I'm lesbian. That's when it gets messed up in the community. But if it fits in a normative, back to that normative structure, things we can get our heads around, we're okay with it. And I've seen a lot of that. And this is why for some communities and for some individuals, they gravitate and they're like, well, I can be out within the context of the thing I can be out with and in the positions I can hold. And so people accommodate and integrate this into trying to have the healthiest lifestyle. But I do think that's a point of resilience within our communities. And in many ways, and we look to our ancestral roots and we look to things like the Yoruba communities and where two-spirited persons actually exist as part of the cultural norm. It's not that unusual. The overlay of the American structure has actually created so much dissonance within our communities that we readily separate ourselves because we want to fit in so much. And so now we're getting beyond behavioral into sociological content. But I don't think you can understand or even have these dialogues about health equity without going across the systems from individual to macro to policy to more fully understand what it is that goes into creating the solutions that we want. And maybe we'll start to talk about solutions before we end, because we're dissecting and diving into the problem. But we have to start talking about, okay, so what? That's the problem. At some point, we'll turn and talk about, well, how do we get to the next level? So I'm going to just turn it over to Dr. Watts.
Yes, well, I think that was beautifully said, Dr. Wheeler. And the point that came to mind for me was it's very much this idea that, historically as African Americans, as Black people, there's already kind of a lot of stigma around your existence just as a person who is Black, right? Who is read as Black, who is a Black life. And so one of the things that I over the years through my research and even being someone who is Black, I've come to understand that a lot of the pushback that we've seen is because this is kind of concept in the Black community that we already have a strike against us. So why would you do something that's even more deviant, even more non-normative? It's like, it's enough that we're Black. Shouldn't you be Black and respectable? And so it's just this kind of idea of like any kind of identity that is queer, that is, again, that's not cisgender, that's not heteronormative. It's not, presenting yourself as in a heterosexual light. There's a lot of pushback there because I would even go as far as taking a historical perspective. A lot of it is for survival. It's literally like, do not bring any more attention to yourself. Do not bring any more negative attention to yourself. It's enough. You can literally be killed just for being Black. So why would you do anything else to put the spotlight on you as being even more deviant? And so that is kind of how I came into my research looking at community belongingness. It ties into this because I did a qualitative study when I was still working on my my PhD. And what I did is I looked at masculinity for gay Black men. And so I did 3 different focus groups of different from ages of Black men from ages of like early 20s all the way into your 60s. So it's a pretty wide range across the lifespan. And one of the things that emerged for me was just this idea of not feeling that you really belong. It's because what happens is you're receiving messages that, if you can't be a real man if you're gay, right? And at least from this is messages that gay Black men are receiving from other Black people in the Black community. That you're not a real man if you're not you know, childbearing, if you're not in a heterosexual relationship with a woman, and if you don't start a family. You know, these ideas again of classism is tied into classism and you know, in heterosexual kind of standards. But there was just this constant narrative of I can't be masculine and be gay. I can't be a man and be gay. And so then, and even there was even conversations that a lot of my participants had where they were talked about how they feel like there's an extra layer of expectation around norms of masculinity for Black men, which I talk about as like Black masculinity, right? Where there was this idea that like, which is tied to this idea of hyper masculinity, where it's like, you know, they would say things like, I feel like my friends who are white, if a white man could walk around with, you know, painting his nails Black, or, you know, have, you know, purple, pink hair, and there wouldn't be this kind of stigma or this scrutiny around, well, you know, is he or is he not straight? And even if that is a question that comes into people's mind, it's not as relevant, it's not as big of a deal. So there's just, you know, there's a lot of data that speaks to this idea of there being this extra layer of expectation of you performing a very normative cisgender life for Black people. And so tying that back into I guess the conversation of why that matters is because what happens is if you are already in a community that is less trusting of the healthcare systems for a lot of good reason, or have you been mistreated historically throughout our history in America, in the healthcare system, and in society in general. And so if you already have a fear or a distrust of seeking out healthcare, then oftentimes the first place you'll go is your community, right? Thinking again about community belonging, it's the community that you belong to, so the Black community. And if you're in spaces where you feel that you can't fully be yourself, that you can't fully talk about, you know, your who you are and your wants and your dreams and who you love and who you want to love and what kind of lifestyle you want to live, if you feel like that's being suppressed and you feel like you're not accepted, then that's when we see I would say, a surge in these mental health issues that emerge because, you know, there's all the stats about you being more likely as someone who's Black and LGBTQ to be more, you know, have higher levels of depression. You're more likely to be suicidal. You're more likely to engage in high risk behaviors than you know, Black non-LGBTQ adults. You're more likely to be diagnosed with some type of disability. So there's just a host of different outcomes that related to your health and mental health that stem from Black LGBT people not feeling that they can actually seek out healthcare services from the larger healthcare, you know, system that we have. And then if you turn to your own community and you feel again ostracized there, then you feel isolated. You're left to fend for yourself. And you know, I just think that it's pretty general understanding that we have that if you're trying to solve your problems, healthcare problems by yourself, you're not going to get the best results. And if you take that individual experience and then apply it to, you know, a huge percentage of the Black community, that's why we see these very disparate outcomes for health and mental health, because you're already afraid to seek out the healthcare that you need as someone who's Black, more than likely. And then you, as Dr. Wheeler had pointed out, then try walking into a healthcare facility feeling as if you're going to be rejected just for how you present or how you identify. Oftentimes you see individuals are then left to feel like they left to fend for themselves or to seek out, you know, healthcare from other individuals who are not necessarily professionals who may be in the same community as you. And so, yeah, you have access to the, you know, the support from them, but it doesn't mean they're going to give you the best, you know, medical advice or the best medical services.
Yeah, and you pose concepts and raise questions for me. A couple things that were brought forward in my thinking as I listened to you. One is you talk about the behaviors, and so over the years and engagement in my own work and both clinical practice and observational work, seeing that people understand these cues quite well, that masculinity is preferred and or femininity if you are a female trying to understand your identities as a woman who is interested in other women. And young folks in many communities, not just in African American communities, I see it also occur in other like Latino communities as well. they understand early, if I just go ahead and have kids, people leave me alone. That once I have a kid, people assume, well, he can't be gay or she can't be gay, they got a baby. And so the rules around protecting yourself against unplanned pregnancy shift because they become part of what you identified as your strategy for survival.
Survival, right?
And so we have to understand what additional pressures we put on young adults when they're coming of age. And this coming of age starts at 9 or 10 when people start to pick up these cues, because then people around them are using derogatory terms or being dismissive of people who are not filling the norms. And they're like, well, that's not going to be me. I'm not going to let people know that. And then they're also rewarded. They hear the rewards for, oh, they've got a family, they got a baby, and that baby. And so we actually reinforce through societal structures some of those behaviors that we say we don't want. The other thing, and you didn't mention it, and I'd love to get Dr. Isaac's opinion on this as well. Some of this relates to misogyny, that this hatred of anything feminine is not just about men not liking things. It's about a dislike for femininity on so many levels. And I know from when I had a clinical practice, the dynamics sometimes that you see between heterosexual or heterosexually identified couples really speaks to the distrust between men and women on some very basic issues, if not dislike of everything other than the sexual connections that those individuals had. And so that, again, this is not just about African-American communities, but this is probably biblical, back to the apple and the snake. I don't know, but this really would take us a long way. But we have to have that discussion that there is a disdain in society, in a male-oriented society that values strength over weakness, that sees women as weaker, that then conflates these issues and sees a dislike for things that are feminine. And that is something to unpack.
Talk about unpacking. Dr. Wheeler, I'm really excited that you brought that perspective in, because I think sometimes when we talk about these issues, we talk about it just as gender or just as sexual orientation, but not thinking about this broader idea of patriarchy and misogyny, and that really does this idea of, I think it's about control, right? You know, there's in our community about, you know, this control and femininity, and like this whole, as we talked about, when you have communities that have been marginalized for power dynamics, then it's this whole idea of, well, I am male and I can have control over this, over things that are female-like or female presenting. And so this idea of being able to control one thing in your life, as you're saying, in the dynamic between heterosexual couples sometimes is something. And I think it does spill over, and it's a really, I think, particularly for the audience that we're talking to, I think you bring a big point about some people may be sitting on this webinar and saying, well, you know, I'm good to my LGBTQ folks, right? Like my community, I'm a good person, I accept them. But what happens in our community as a larger kind of ethos of how we treat, like you said, femininity, and think about that actually spills over into what the impact on the health of other groups and how they see themselves. And so thank you for bringing that out, because I think that's a really important point. And one that I don't think is always brought out, but one that's huge in our, I mean, we're seeing it right now, right? We're not even seeing it as something as small as, you know, not to bring Rowan to everything, but Dobbs, you know, now we're talking about IVF, and that has a huge impact on LGBTQ folks, because people who want to have, people who are open and out and happy and in loving relationships now cannot have children, may not be able to have children, because we might outlaw IVF. Like we're to the point where that's where we're going. And so the impact is not only on heterosexual couples, but on also LGBTQ couples who want to start a family, because, you know, it's fascinating that, yeah.
You know, but to my point, this is going to sound like a little off the cuff and kind of comical, but people just go back to the old-fashioned ways of you know, that it's not going to stop people from, you know, but your point is well taken. People have developed that, you know, access to alternative means to raise healthy children because they want the children. They want to nurture the children. They want to be good parents. And why would we want to deprive them? And to your point, this larger issue, I say it's not just about African-American Black communities, this issue of control and taking control away in a male-dominated society to say, I can do that to you. Nobody's cutting down on the access to Viagra, and that's a problem.
Well, drop the mic on that one.
Yeah.
Dr. Watts.
Well, I don't have anything more to add per se, but I think when I hear this, one of the things I think about, and I love that you all made this point, that it's not at all in any way unique or specific to the Black community, the misogyny. But I do also, I think about, this kind of hatred for things that are seen as feminine, or fear, or pushback, right? Makes me think a lot about the way in which the Black community over time, especially since the war on drugs and mass incarceration, how there's been so much of the absence of Black men and Black fathers, not just in the community, but also in the family. And so then what happens is, I think about how even for women, Black women, it seems like there's this almost this, whether it's explicit or implicit, this understanding that I have to be more masculine to survive in the world. I have to be more masculine to make sure that I can secure the type of employment that I need, is to make sure that I can be the mother and the father of my children, right? So I think about how that also plays out into the Black family as well. And this is not specific to LGBTQ people, and how I see that reflected sometimes is, there's again this conversation around the experience. So what I hear, I don't have any scientific data per se that I am aware of at this, but there's a lot of conversation around when someone is seen as masculine and as a woman, whether she is, identifies as a lesbian or seen as such, there's a lot more like acceptance of that. Or like, people like, oh, my aunt who's gay, people will say whatever. But there's a lot more of a stigma around when it's a man who is gay, right? So even when you brought up the point again, Dr. Willer, about this, what you made me think about is how I think about Black men who would be truly okay with being in community with being, in connection with, say, someone who is a woman who presents as masculine, identifies as masculine, and there's no issue with that. They're not concerned about anybody finding out, or that they have to hide how close they are, or, try to diminish the nature or the extent of their relationship. But then if it's a man who's seen as effeminate, or, even more so, say someone who's transgender, a trans woman, then there's this complete, pushback and violence and hatred that oftentimes you see, that comes out of that. And so I don't, it's not necessarily an answer, but these are the ways that I see this misogyny playing out in the experience of LGBTQ folks in the Black community, where there is a privileging of masculinity and male identity. And even if you look at spaces that are largely, like I think about the ballroom scene, right? Which is, there's a premium, like, so, and in case anybody, I'm sure people who are at this webinar may be aware, but just in case you don't know, it's just basically like the kind of, I don't want to say underground anymore, but it's the very much the ballroom scene of people voguing and Black queer people coming together and having houses, and the balls becoming these really big social events where people, compete for prizes and awards based off of their ability to, vogue and dance. And there's also categories like sex siren and things like that. And one of the things that always stands out to me is that when it comes to femininity, it's celebrated as how real you can pass to, say, someone who's a transgender woman, of being, can you show yourself as a real woman? But there's a premium put on anybody who's masculine. So it's like, it's interesting kind of interplay where it's like, we love people to role play and to put on the costume of femininity, and as a woman, we love to, we like to play in that, and celebrate it and cheer it on for entertainment. But if you actually look at these same trans people, if they had to choose between supporting someone who is a heterosexual man versus another trans woman, chances are they're going to privilege that relationship with someone who's masculine, someone who's seen as a man, right? So that's just so curious to me, because I think that is a large part of what we see in our own kind of inability to really be in community that we need, the way we need to be as for Black LGBTQ people, because we're pitting masculine and feminine people against each other. in ways that are not really conducive to us actually, supporting each other. It's not conducive to our health. And oftentimes it makes us almost enemies of each other when we should.
Yes.
When we,
Well,
go ahead, Dr. Wheeler.
I mean, you raised so many great points, and I know we're going to be time constrained, but I do want to go. I want to go to a basic level. I mean, I introduced the misogyny stuff, but I just want to talk about the concept of sex. And what I mean by the concept of sex is if sex didn't feel good, if it felt like a migraine every time you even thought of it, we wouldn't be having a lot of these discussions because it just wouldn't be a thing. It surely wouldn't have the rates of HIV that we have if every time a guy got an erection, he got a migraine. It would be over. It would just be over. We live in a world where we're not comfortable with misogyny and we're really not comfortable with sexuality. It's something you do in the dark. It's something you do in private. You may talk about it within mostly your same gender communities. You brag about it. You talk about getting some. You talk about whether he was any good or not. So, I mean, you do that kind of, right? You do that kind of talk, girl, you're going to give him some kind of thing. I give him a little bit. He can have a peek of that. Whatever that might be in your world, and we're laughing, but it's important to bring a little bit of humor to something that is so difficult for normal conversation. It is considered untenable in most normal conversations that you would talk. And I won't do it now because this is going to be recorded and I'll be on, for life having said these things. But when we talk about the anatomical parts, we're stripping it away from even schools now in some jurisdictions so that people are even less equipped to talk about the loin and the groin and the feel good and why you do it. If we don't start to have those discussions, we can't have healthy adult relationships because we don't build in the building blocks, whether those relationships are straight, gay, or trisexual. And trisexual means I'll try anything at least once. And you can have people that can live across the fluid experience. And, in some of my earlier research, you talk about the difference between your identity, your behavior, and your use of your sexuality in situational circumstances. And that means you may identify as straight, but you may be attracted homosexually to someone of a like cis status as you, but behaviorally you may do something inconsistent with both of those, but situationally you might do something that's convenient for the situation to make money, to do what it's, and so we often attribute one of those things is the defining thing for who you are. And so if somebody says I'm straight, but then they have sex with somebody of the same gender, we say this is messed up. Well, why is it messed up? They just told you this is how I identify. That's on me to disaggregate that. And that's where I'm going with this, is right back to my earlier comment and why I think it's relevant for the audience that you've brought us to speak to, Dr. Isaac, is that as folks engage with communities, we have a responsibility and an obligation to see that it is not the pathology necessarily of the person that we're trying to bring across, but sometimes it's the pathology of those of us who are trying to do good. And by doing good, we're actually forcing our agenda onto other people because it's what we want them to do, as opposed to us stopping and listening and saying, what is our community telling us about who they are, what they want, and how are we taking that indigenous knowledge to bring better outcomes? And as you start to look to solutions, when I suspend or reduce my own biases long enough to listen to your point, I usually come out of it with a different understanding of who you are and ways we can work together without me being threatened by things that may not fit well for me in my behaviors, but really are not a risk to me because you just don't see the world the same way I do. And I think that's where so much of this gets stuck.
And I would add to that. I think you hit on this pretty much, but that makes me think about how there's a lot of work, therefore, as a professional, as a service provider, as a healthcare provider, too. A lot of times it takes some real kind of internal reflective work, because it's always a question of why would you be uncomfortable talking about this with a patient or a client, right? Why is it that you would feel as if you need to deter them from certain behaviors that isn't, you know, inherently harmful to them, you know, outside of it just being something that you wouldn't do or something that you've been taught isn't that you shouldn't do, right? And so I think that was a great point that you bring up, Dr. Wheeler, which is, you know, it makes me think about how it is therefore incumbent upon you as anybody who signs up to or takes on the title of being in a position to provide services, to provide healthcare services, mental health services to individuals in the LGBTQ community. I think that maybe sometimes there's an overestimation of how prepared and how educated you are in being able to do about that and prepared to do that. I think that there's just a lot of assumption like, oh, okay, well, I mean, I have gay and lesbian, you know, family members. I have gay and lesbian, you know, friends. I know I watch polls. You know, I've seen the movies. I've seen the TV shows. I mean, what else do I need to know? And I just, you know, I don't want to be redundant on this, but it just always goes back to the perfect example I always think about is the transgender woman not getting a prostate check, or the masculine person, man not getting you know, a pap smear, simply because of the fact that in some cases it may simply be because of a lack of awareness or knowledge on the part of the healthcare provider. It may not even be an explicit kind of bias or discrimination. It's just simply you just made assumptions about this person and about what they need and how you should provide services to them, because you just assume that I know everything there is I need to know. And then to take it to the step, you know, back to the conversation about what will make you uncomfortable with, you know, having these conversations or working with an individual. That's some internal work that you have to do. You really have to sit with and understand, you know, why is it that I would be uncomfortable with this? Why is it that this is something that I feel unequipped to work with? If it isn't due to a true lack of training, you know, I can understand if you're a dermatologist, you're like, okay, well, I don't really know how to give you, I'm not an ophthalmologist. I can't help you with your eyes. I get that. But, you know, as far as being able to simply, you know, you need to be sure that it is your responsibility to make sure that you are aware and educated on what it is that individuals from the LGBTQ community are going to need when you're providing services for them. And it's not for you to just assume that you know, or you should do the work of actually, you know, seeking out, whether it's trainings, whether it's reading articles, reading books, you know, it is on you to figure that out. It's not on the person who comes to you seeking help. That is not their responsibility to educate you. Now, of course, I think it is good practice to ask questions if you're unsure of something, if you're unaware. I think you should always ask questions, even if you think you know, because now we get into the place about having biases and making assumptions. So I think that you should always still get the information that you need from the person that you're working with and ask the appropriate questions. But how are you even going to know what are the appropriate questions to ask if you're not educated on what the experiences and the health experiences of this person, however they identify, is likely to be?
And
go ahead, Dr. Wheeler.
I'll try to be brief.
That's okay.
I would just add to what you said, Dr. Watts. In addition to how would you know, it's also, are you willing to suspend your perception of expertise and that you must control the conversation long enough for you to ask the fundamental question, what is your goal? What would you like to accomplish? How can I be of assistance to you in accomplishing that goal? The suspension of that hierarchical approach allows you to listen to what that person's goal might be. The person's goal might just be to have a pleasurable family relationship with my spouse. Okay, now we're talking about something different. What turns you on? What turns your spouse on? What haven't you told? You can have a different discussion, and that's when you get into useful questions. And the other thing is to treat people with the person first orientation. Now, what does a person first orientation mean? We started this out, LGBTQ, that's a label. Start with the humanity of the person in front of you and ask the fundamental question. Tell me about who you are. Tell me about things about you that you would want me to know. Not the labels that you hold, but tell me who you are fundamentally, the personage. And we spend a lot of time, and I think even more so with the rapid fire systems around of social media and other things, quickly labeling or giving somebody an emoji that is supposedly describing the entirety of the person. I'm way more complex than the 64 years that I've lived and the experiences that I've had. And yeah, I got you, didn't I? So this is a big year this year. I'm turning that next one. And so I've seen quite a few of these, and I'm living through it myself on a number of levels. But people need to stop and ask, who are you and what do you want? Before you start prescribing what it is you want that person to have.
I love that. And we got about 8 minutes, and that's okay. And so people have questions. I want you to put it in the question and answer. But this brings me to a couple of questions. I definitely want to get to our solutions question. And this question somewhat goes into that. The group that we have on this call, but the wider group is, mostly folks who are providing services, social services to folks. And so what I want to talk about, because I think it's really important, I think both Dr. Watts and Dr. Wheeler talked about this idea of, yes, we want to do whole person, but it's about the questions you ask. And I know we have gotten pushback on other times where we have tried to ask questions about, gender identity, and people are like, well, I don't need to know that. Why do I need to know that? I'm not, for example, their healthcare provider. I'm providing housing, or I'm providing other services. And so I wanted to talk about the importance of data, the importance of representation, and the importance of knowing the right questions to ask. And so I'm going to keep it there. And I want the folks on the line, if you have questions, to put it in the question and answer. But I'm going to throw that question out there.
I think, Dr. Wheeler, I don't want to be redundant, but I think that Dr. Wheeler made a great point in speaking about, thinking about the person as a whole. And the reason why how I see that playing into what you're asking is because it then allows you to see them as a whole person who is beyond whatever labels they have. Oh, how are they identify? And at the same time, I think that when you take a step back and see the person that you're working with as another human being, it allows you to take off this kind of lens you have. Okay, I'm dealing with a lesbian woman, so I need to ask her about these things particular to what it is that is the life of a lesbian woman, as opposed to, taking a step back and really getting to the place of like, so what is it that you need? Obviously you came here looking for some type of service, or, what is it? What are you presenting? Tell me what's going on. What's happening? Allowing the person to actually, because a lot of times you'll find that what it is, people don't always necessarily know. Like, I mean, if you're in a healthcare, context, then sure, I'm coming because my chest, I'm having pains in my chest, or, maybe something is irregular in my body processes. But if you're thinking about health more globally, and even like in the work that I do, which is mental health, a lot of times people aren't always quite clear on what it is that they actually need. They may be able to tell you what they're feeling, what they're experiencing. I've been really sad. I've been really, I've been having this thing happen where my heart really starts to rush whenever the certain, context happens, or I'm finding that I've lost all motivation. I don't want to do anything. I don't want to go to work, blah, blah, blah. And so it's the complexity comes in, and having an understanding of intersectionality and intersectional identities is that it gives you more context for how you can then perhaps steer the conversation, because you can ask things about, well, I know that you said you are a lesbian woman, right? So when you ask about questions relating to maybe their personal life, the type of interpersonal relationships they have, that gives you some further context as to what maybe particular things you may ask down the line. But at the very beginning of the conversation, you should be asking them the same questions you would ask anyone else. And then once they start giving you information about, well, I feel alone, or, or maybe they tell you something about their children, right? Now, okay, I didn't know you had children. So they may bring you some conversation about what their family life is like. I'm single, or my partner, such and such and such. So, then that allows you the opportunity to start. I always look at it as a funnel. I always talk about like getting a broad kind of understanding of the person. And then as you work with them, it allows you to actually get more narrowed down and more specific about and what is happening. And this is where your expertise as a professional is where it really kind of serves and comes in. Because now that you have this broader context and understanding, you can say, to yourself, based off of what I know about people and this type of work, based off of what this person is expressing to me, typically this is related to this. Typically, these types of feelings, these emotions, experiences are related to that. You may just say, oh, well, is there something going on at work? You know what I mean? You know, you can really start to understand what treatment is most appropriate. And you can also, therefore, it creates a space where the individual or the people, the communities, you know, you may be working with multiple people at once, depending on what type of work you're doing, or you may be working with one person. But what happens is that it creates a space where the people, or the person that you're working with has a sense of agency in the process. So now they feel that they can trust you because you've already demonstrated to them that you're interested in them as a person, as a whole person. And yes, me being a lesbian woman is likely going to be central to my identity and my life experiences. But is that how much does that really matter when I'm at work? You know, like how much does that really matter when I'm going to the grocery store and I can't afford to get food? You know, how much does that really matter if I'm having a pain in my chest? You know, so I think that without going on and on about it, I think this is the really, really important point to make about, you know, starting with them as a whole person and allowing the person to tell you what is important to them, but also you having your expertise to also be able to think about other questions or other information you may need in addition to that, based off of what you know as an expert, in addition to the person being an expert on their own life and themselves, and you all coming together and meeting. And therefore now you can have a holistic understanding of what's happening. And you also create an empowering setting where they're more likely to want to continue to work with you. They feel comfortable with you. And they may have some friends who also need similar services that would not have come to you or anyone else. They may not they may have decided not to seek out any help at all because of the same kind of stigma and oppression and structural oppression that we talked about. So now you're not just doing work for one person when you do this, you're also potentially creating a space where they can tell other people that, hey, this is a resource that would be really appropriate for you and really good for you. They've really helped me out. I didn't feel like I was being judged. This person or this team saw me as a whole person. And so now, you know, you're doing the work starts to kind of, you know, scale out. If you do it correctly, it can.
And the only thing I would add, because we're on solutions right now, because I talked about person focus, I talked about addressing the basic issues of sex and misogyny. I'm going to speak to the National Urban League, your affiliates, as well as because you asked also Dr. Isaac about the role of data. The National Urban League and its affiliates are probably in a unique position to collect, gather, analyze, and deploy data to some of these critical issues because of the affiliates and the networks coming up within in your area of health equity, having an annual agenda that allows you to explore through your network some of the best practices, some of the common issues, some of the behavioral, psychological, biomedical kinds of concerns. We're going into an age where people like me are getting older. People are living in an LGBTQ life. What's that look like? And so using your National Urban League network to say, hey, can we talk to across these 95 affiliates or 90 affiliates, can we talk to people 55 and above who are aging in LGBTQ space? And understand how we can assist them, because many of them, like myself, will have lived and amassed certain kinds of accoutrement of a good life. And so we're not in absolute need, but, you know, living and getting older and looking at life may look different. So I think, and how we then would do the same for younger populations. So I think the network of the National Urban League is a phenomenal resource. And also, and I was excited in this earlier point, LGBTQ health as a health equity issue is great for straight people too, because it forces these questions that we've been discussing. It opens up the door behind the velvet curtain. It opens up an opportunity for us to be more fluid and engaged. So I hope that people have enjoyed the discussion, and I turn it back to you, Dr. Isaac. I certainly have enjoyed my time.
This has been wonderful. I want to thank you both so much because the conversation totally went in a different direction than I expected it, but it went into a great one. And so I think we talked about concepts and issues that I didn't think we were going to talk about, but are important and are not talked about in other forums. And so that was actually my goal of starting this series, was to think through, these topics are old, or are not new. Many people have talked about them, but to think through different perspectives and how we think about them differently. And so this was actually one of the best discussions because of all the different directions it went through and all the things we brought together, because it talks about that. It goes back to fundamentally what we've been talking about, right? Somebody's health is about them and the person in their community, and they're not these separate things. We have to look at people in their totality. We have to think through all the social determinants of health, all the policy issues that are impacting folks, all the personal issues that are impacting them, their intersectional identities that bring their life experience. And you know, that's a lot. And to this audience, I want to say that's a lot. But I think if you, as both of you said, we come at the folks we serve with humility and understanding and openness, it doesn't matter that you may not know all the answers, because you're coming. I think that was the point that from this, as long as you come with openness and humility, then people are going to help you find the context that they need to help them and serve them in the right ways. And so I want to thank you both. We are over time. I want to respect your time and our folks' time, but we will have to continue this conversation because it was so great. And I just appreciate you. Enjoy the rest of your vacation, Dr. Watts. Dr. Wheeler, so nice to get reconnected and see you again. I'm really excited, and we will let you all know. This will be on our YouTube page, hopefully by tomorrow. And everybody have a great day. Happy Pride. Pride will be over in a couple of days, but I just want to say happy Pride. Thank you all so much. Have a wonderful afternoon. Bye-bye.